to go back 21 years. I was a young investigator at Johns Hopkins University, and I had just finished sequencing the DNA from blood samples from some people that they were in families that they had hereditary form of colorectal cancer. I noticed some changes in the DNA. Next day, we gathered the whole team, and we knew exactly what we had. We discovered the genetic basis of hereditary form of colorectal cancer. That was big news back then. We got great publicity. We got great publications in scientific journals. But I didn't understand the importance of these findings until I actually met some of these people whose blood I used to find those findings. A colleague of mine, a doctor, invited them at Hopkins to see and meet us. I reluctantly went to an auditorium there, and mostly because I was curious. I walked in that little auditorium. They were sitting in chairs up on the stage, and the doctor started introducing them to us. And I noticed, and all of us noticed, this tall American, beautiful woman, probably her late 30s, early 40s, that she was sitting there crying. The doctor stopped and turned to her and asked her, "Why are you crying?" And she said, "Well, I feel guilty." The doctor was taken aback. He said, "Why you feel guilty?" He said, "Although I understand that these findings probably going to help my family, I still feel guilty because I passed the gene to my 10-year-old son, and now he has a great risk of dying of colorectal cancer sometime in the next 20, 30 years of his life, maybe sooner." After she overcame that emotional moment and through the conversation, she actually in the end started smiling and realizing that this information was very important to the doctors. We knew that this person had this 10-year-old had that great risk, but there was not a single cancer cell in his body yet. And then the doctors were able to manage him such as that he wouldn't die from the disease. Sometimes some of the decisions that people like that in high risk make are very difficult. Angelina Jolie made a difficult decision last year or so for a different form of hereditary cancer, breast cancer. But both the 10-year-old and Angelina Jolie, what they really did was they prevented cancer from growing in their body. And that's the power of pre-symptomatic diagnosis. But the hereditary forms of cancer, there are only less than 10% of the total number of cancers. So what are we doing with the other 90 or more, actually, percent of them? The World Health Organization, just a few months ago, 6 months ago or so, had a report on cancer. It's telling us actually that in the next 20 years, we're going to have more cases per year, going from 14 million to 22 million, and more deaths per year, going from 8.2 to 13 million deaths. This is data from the United States. What it shows is how many people die per 100,000 individuals from different diseases. Cancer is that blue line that says number 2, malignant neoplasms. From the 60s till now, it has stayed the same. Even heart diseases that they used to be the number 1 killer in the Western society, they're now becoming the number 2 killer. So what are we doing? Are we having the correct approach to fight cancer? This is the number of letters that our DNA has, a single copy of our DNA. And these are 4 to 10 misspellings that they will change the meaning of some words that cancer needs to develop. Those misspellings, of course, there are the mutations. There are changes in the DNA sequence. And what those changes do is, first of all, there are the weapons that cancer uses. That's what it uses, those 4 to 10 changes in order to grow. What those changes do, they upset the balance in a tissue between the cell birth and the cell death. You increase the cell birth, you have growth. You decrease the cell death, you have growth. And that's the essence of neoplasia. In the lower part of this slide that you see behind me, it says that cancers, as they grow, they accumulate multiple mutations. And they come to a point that there is uncontrollable growth. Cancer grows in a microenvironment. Could be the liver, the lung. And these mutations are in genes that they make these cells to adapt and survive in that microenvironment. How can we turn those weapons that cancer uses against them? Well, we as a scientist, and also as a society, I would say, we have decided that we're going to try to cure advanced cancers. That's our plan A. We have designed different therapies. Some of them are targeting directly the mutations. This is a case of a 38-year-old that has melanoma, multiple lesions all over his body. He was treated with a drug that targeted a mutation in a gene that is called BRAF. The details are not important. A few months later, that's how his body worked. It works. We target the mutations, that's what happens. But here's what happens a few months later. The cancer gets new mutations. And now the tumors are resistant to the therapies, and there wasn't anything to be done for this individual. This is my uncle Nick Papadopoulos, same name as me. We're very close. And he had a few years ago that cough that doesn't go away. It doesn't sound serious, but it just didn't go away. Eventually went to see the doctor, and within a week we found out he had terminal metastatic lung cancer. Devastating news for him, for the family, for me. He elected to go and use some experimental drugs, and that did prolong his life. He was supposed to die in 3 to 4 months. He lasted a year, but that's hardly a prolongation of life. I spent a lot of time talking to him through that 1 year. And through our conversations, some of them very private, but he said a couple of things that they actually made me feel embarrassed as a scientist in the field. The first one, I remember outside in his garden. He was living in Houston, Texas at the time. I was sipping coffee. He was sipping his favorite drink, a little bit of whiskey. And he said to me, "Nick, you know me all of my life. I didn't have the best life, but I fought every obstacle that it was thrown in front of me. And I didn't care if I won or if I lost, as long as I knew how to fight, and I put everything behind that. I don't know how to fight this. I feel hopeless. And I have a feeling that my doctors do not know how to fight it either." As the time went by, this year, the months went by, he got very weak. Actually, the last time that I saw him, he was on the upper floor of his house because he couldn't go up and down the steps anymore. They moved his bedroom next to the bathroom because he couldn't move much. But in one of the last conversations, he looked at me and he said, he didn't call me Nick that time, he said, "You scientist, why it had to be the cough and you didn't have something else to tell me that I had cancer before it was too late? How can you not feel embarrassed? That's what I've been doing the last few years." What happened in both for this person with the melanoma and my uncle is the tumor was discovered when it was advanced. It was too late. That's when people have symptoms. That's why you go to the doctor. But most of the times you cannot cure them. So what he was asking is, why can you find it earlier when it's curable a lot of times, but there aren't any symptoms? It's almost like you have to screen healthy individuals. But we know that screening works. In colorectal cancer, for example, when people get diagnosed with stage 1 or 2 disease, what we call localized disease, 90% of them survive. When they get diagnosed with stage 4 or advanced disease, 90% of them die. So, shouldn't early detection or putting resources in early detection, instead of being our plan B, being our plan A? And I think as scientists, as a society, we do need to decide to do that. And when I say resources, it's not just money, it's ideas, it's innovations like we heard in the first talk. It's putting bright minds working to try to figure out how to do that. We need one of the things that we feel we need is non-invasive tests, so they will be easy to administer. And we're using mutations, those weapons, again, against cancer, because they are specific to cancer. They are present there from early stages, and with the presence of mutations equals the presence of cancer. So imagine now that you could see those mutations, or in other words, see that cancer in a vial of blood. It's a big task. A lot of DNA is shed in our bloodstream, and that's normal. And when we have cancer cells, or when a person that has a cancers in his body or in her body, then they will have DNA from the cancer cells in the bloodstream. But it's a big task because it's such a small amount compared to the rest of the DNA. It's like looking for a needle in a haystack. But our group and other groups around the world are working on that. And now we have methods that actually can look each molecule individually. It's almost like you take the hay one by one till you find the needle. And those are fast and cheap, cheaper than other methods that are available. So we are creating those tools. And they have many applications, actually. I'm not going to go through all these applications. I'll give you one, monitoring, for example. What is that? A doctor treats a patient with a therapy. The tumor appears to be going away. Then always the question is it coming back? How do we know? How early can we know it? Can we have a test that we can keep doing it to give us an idea when those things are coming back? So it's exactly the same technology, trying to identify mutations and give this information to the doctor. But my favorite one, and perhaps the most difficult, is screening and early detection, or what I've been calling through this talk, prevention of advanced cancers. Recently, we performed that test in about 600 or so, more than 600 individuals, and indeed, we can actually identify mutations in the blood from individuals that actually have early stage cancer. So for the first time, we feel at least that this is feasible and perhaps within our grasp in the next few years. So really our vision is to prevent or decrease cancer deaths by finding cancers before they become advanced. With non-invasive tests in a yearly office visit, with routine biological samples like blood. The same test can work in urine or in other biological fluids. And for biomarker analysis, we use mutations for the reasons I told you. So I'm going to leave you with this word again, prevention, not only in terms of changing the lifestyle, reducing smoking or eating better. Those things are very important too. But also learn as society first to divert or add more resources towards developing those technologies for early detection and these tests. And second, teaching ourselves that sometimes we have to take those tests when we feel early, and that's the time that we can actually catch the cancers early and perhaps prevent them from becoming advanced. Thank you.